Hi, folks. This is Dr. Rob Sivers, the Carb Addiction Doc, and we are so honored with somebody I'm going to call a friend of mine, Dr. Angela Stanton. And I've known Angela for quite some time. And the interesting thing is, we were just talking a little bit ago, she's very similar to me in terms of her inquisitiveness. And we're going to explore the concept of migraines, and she considers herself to be a migraineur and is specialized in this, not intentionally, but vicariously, like I did, coming from my own background and understanding and developing a specialty thought process. And she's been doing this for over 15 years, having suffered since she was a young child. One of the things when we get introduced, we're both PhDs, but I can wallpaper a small house with a number of degrees I have, and they're irrelevant to me except for the fact that I can check those boxes. And Angela's kind of the same. Really what comes down to this is our practical and our pragmatic experience and our thought process and the advice we can give to people. So while Angela is highly decorated, well-known, done tons of podcasts, the most important thing is this woman is an absolute expert in helping people to understand migraines and then have a practical therapeutic approach that I know works. I refer, when my patients, and a lot of them have a list of, migraine, I'll say, look, we're going to put brackets around that. I'm going to send you Angela@migraine-book.com as an email. Reach out to her, tell you one of my patients, and she's much, much better than I am at helping you. Today, I'm going to share this on our channel, her expertise. So welcome, Angela. Thank you so much.
Thank you for inviting me. It's really a pleasure meeting you in person, finally.
Can we start with your own personal story just a little bit?
Sure. I can't be exact with the date, but right around in my early teens, maybe 11, 12 years old, that is when I started my migraines, but they were very atypical. So what we would call today as migraine as an adult is very different from what children are diagnosed with as migraines. So my migraines were children-like, so to speak. So I had irritable bowel syndrome, cyclical vomiting syndrome. These were the kind of symptoms. I don't recall having a headache. I may have had a headache to go with it, but I just remember extremely painful intestinal issues. And we were just always told, it's just probably some bug that the kid ate, whatever. So the problem that it didn't surface was because at that time, nobody tracked the time of the year. So I am not young, I'm in my late 60s. And so my primary time when I started my migraines was in the early 60s, 1960s. And so at that time, we didn't eat, back in Europe, I'm from Europe originally, we didn't eat a lot of sugar or carbohydrates. We typically ate just a regular, what was available, mostly meat, some grains, some potatoes, but usually it was a lot of meat. And we only ate fruits and vegetables and sugar seasonally. Sugar, for example, ice cream, you couldn't buy ice cream in the dead of winter. You had to wait for summer. It wasn't in the stores, you couldn't buy it. And so interestingly, all of my episodes, as I recall, were in the summertime. And so there was some seasonality to it that nobody discovered. And so this was a puzzle for me. So when I today talk to parents whose children have irritable bowel syndrome or cyclical vomiting syndrome, the first thing that comes up to me is it seasonal? Is it something that is, but of course today there's no season. Everybody eats sugar all day long. And so my first question is immediately along the line of nutrition for the migraine and whether it is a migraine. Are there any other symptoms? And so this is my background. And I didn't really have an official migraine that they would today call a migraine with a headache until after the birth of my second child. So we're talking about, I was maybe 29 years old. And it sort of kind of increased over my life. So as many doctors tell women in particular, well, when you get into menopause, you are premenopausal, you will not have any migraines. That wasn't the case. It actually increased. And so, and I have been talking to a lot of others since then, similar situation. And so this started me working. So in my 50s, I started to work on migraines because at that time, I already had migraines 5 days out of the week, every single week. And I was completely useless. And to the point, I quit my academic job I used to teach. I was at Max Planck Institute in Germany, working as a postdoc, as a guest researcher. And so I had to quit all that because I was just in constant pain. This is what started my research in migraine.
Fantastic. So I told you we were going to bounce around a little bit, and I'm very intrigued by something you've said. So I'm going to go a little sideways here, and because what you've talked about is something I've never heard talked about, is the childhood migraines. And one of the interesting things when I looked this up, and this is academic knowledge, not practical knowledge, but in prepubescent kids, it seems like there's a 3-to-1 incidence of boys having a higher incidence of migraines than girls under that 12 to 13-year age group. And biologically, the boys and girls hormonally are much more similar before the girls have gone through menarche and the boys have started to mature. So just a comment about that. And I think you mentioned that this is often abdominal symptomatology that is the expression of the migraine. And so first of all, the comment is about boys versus girls. And really what this is about is raising an awareness of abdominal pain that's unexplained. It's not appendicitis. It's not the other things. Could this be related to either migraines, or the question really for you, you're looking backwards at your own life. Is this truly a migraine? In other words, starting in the brain and going to the gut, or is this just a prodrome of insulin resistance? Because we know irritable bowel, we know that some of the GI, not so much the vomiting, but reflux are caused by chronic excessive carbohydrate consumption and early insulin resistance. Is this an association? Is it a direct causal effect with the migraine itself? Because you said you didn't really have the headaches, but you had the abdominal symptoms. Could you tease that out for us a little bit? But I am fascinated by raising this awareness with so many moms who are doctor bouncing and not getting adequate answers for their kids. So I love that already. That's already blown my mind.
So here's another point that I would like to add to that before I answer your question, is that a couple of recent academic articles point to the fact that a child, a baby that has colic, is actually a migraine baby. There's no proof of this, but there are several articles that suggest that already at that early age, a migraine may manifest in a completely different and unexpected way. It may be equivalent to a colic. So this sort of kind of answers your question, because you don't expect a large population, 12 to 15% of the population has migraines, and so do children as well, 12 to 15%. Obviously, it's the same kind of a ratio. You don't expect a newborn baby that is colic to have type 2 diabetes or be metabolically sick. Not yet, anyway, maybe later on, and maybe there's a genetic association there which we can talk about. But I think, and this is a hypothesis of mine, is that we are born, migraine is genetic, that we know. That's not a hypothesis. We do know it's a genetic condition.
Are they all genetic? Because I know that there's a correlation with certain genes. Is it always genetic?
It's always genetic. The question is, at what time, what age does it express? And it will express based on the epigenetic factors. So one can silence the genes with the proper epigenetic influences, and one can activate the gene at the improper epigenetic influences. And whether something is proper or improper is dependent on the person and obviously the location and also the age. So you mentioned, for example, boys in puberty. Right around that time, their appetite increases. They will eat anything that moves. That may be one reason why it gets expressed, because they may not be eating the right kind of foods. With this said and done, there are children or boys in this age group who eat completely fine and may still start to express some migraine symptoms, which can have an evolutionary backdrop, which is something that we want to talk about later.
Let me just stop you for 1 second. Is there any correlation in your knowledge with testing for insulin resistance and those young kids? Because you're right. We don't make that correlation. We don't make that association in these young kids. Is there any evidence where people have looked at these young boys with these symptoms and correlated with insulin resistance or with hyperglycemia?
I don't know of any one case where children are specifically who are suspected to have migraine are tested for metabolic disease. So I wouldn't be able to give you that answer.
But heads up there for pediatricians, I think it's a reasonable thing to look at when you see these.
It should be
perplexed by it.
It should be, because in my Facebook group in the migraine Facebook group, the protocol group, which has about 12,000 members, I do look at the metabolic health of everyone who joins. And I have many mothers, some bits up to 6 children, of which maybe 2 or 3 have migraines already at a young age. And I do put them through a test, which is like a Kraft equivalent, the Joseph Kraft test, which I assume some of the audience don't know. It's a 5-hour postprandial blood glucose. And in my case, instead of insulin, since I am not a medical doctor, so I can't order an insulin test. I can ask a doctor to do it, but it's usually refused. So what we do is an at-home where we control the food that they eat. I mean, know precisely what they ate. And then we take a 5-hour blood glucose and blood ketones test. And with the combination of the two, I can use ketones to look as a proxy for insulin. And so I can estimate an approximation of their metabolic health. And I take this every half an hour. So the mother is taking that. I'm not with the patient. This is all through Facebook. And then they post their results. And I have sort of predetermined normal curves based on whether they're going to eat a regular diet, a standard American diet, or a normal curve for a carnivore or a keto. I have different kind of normal curves of what the expectation would be.
And what Kraft levels do they correlate with? You've got the 5 different patterns. What is the pattern that you most commonly see in your migraine population?
I see for the children, I see very slight variations toward pattern 2, where they will have a delayed response. And then in the adults that come in with migraine, and by now I have a lot of people coming in who are not migraineurs. So I have a mix of findings. I find that most of the people who are tested, who, by the way, have never been tested with diabetes by their doctors, or not even insulin resistance, which is a form of diabetes, they were never tested, and not one of their markers show that they have metabolic disease. But on this 5-hour test, they show level 3 or level 4.
Right. So let me start. We use the Kraft test a lot. I actually do it because I'm a physician. I can do it with insulin and glucose. We don't do the 5-hour. We tend to do, for most labs that are comfortable doing a 3, I can push them to 4 hours, but it still gives a good tracing. And I've created the concept of, for my pattern 2, I call it insulin resistance 1, where there's a delayed response, but you start with normal glycemia and normally low insulin. And then the 3s are where your insulin level is elevated. You start with a low blood sugar, and it's a much more delayed pattern. So that's IR1 and IR2, and it really depends on systemic blood glucose elevation in response to an elevated insulin. And over time, that fasting blood sugar never comes down to normal in the IR2, which then becomes type 2 diabetes down the road. I'm going to stop you. I want to come back to this, but I want to circle back to something else that, again, I told you my head operates this way.
Sure.
Colic and these young kids. I'm going to ask you just a quick question, and then, because I want to follow on this, where do we believe in the brain migraines are most prevalent? Which part of the brain?
Okay, this is a very important question, and it can be anywhere within the brain. The symptoms tell you where it is occurring. So for example, if I suddenly am unable to talk, and there is actually a newscaster who was reporting on something, in the middle of the report, suddenly all the words ended up garbled, totally backwards, made absolutely no sense, and she was not even aware of it. And of course, they took her to the hospital. They thought she had a stroke, but all she had was migraine. So, well, we know that if it is in fact the speech that is affected, then it's the Broca area in the left part of the brain, right? If I see an aura, that would be an occipital cortex region in the opposite side. If I have a hemiplegic migraine, that's going to be on the other side of my brain in a bigger area, which controls all my movements. So there's no one set area in the brain where this can occur.
Well, let me take you to where I'm thinking about, because when you're dealing with babies or children under the age of 5, you've got colic. The 2 things that leap to mind is, number 1, the human brain continues to structurally develop through the first 5 years of age. So that human brain is not completely structurally normal yet. And you've got obviously white matter development, gray matter development. But when you're talking colic and GI symptoms, cyclical vomiting or vomiting, irritable bowel, that sounds more autonomic to me. and more at a basal ganglion level than at the cerebral level, the gray matter. And the question is, can you get migraines at the basal ganglion level?
Absolutely. Yes, you can.
Wow. Okay.
So yeah, you can get it in any part, and the manifestation is going to evolve over time, because basically what we are talking about is where the brain has not yet evolved to the proper adult form, it can't have a channelopathy. So we can talk about this at any time, that migraine is genetic, of course, but it's a form of channelopathy. And so what a channelopathy actually means and how it evolves and how it is presented is dependent upon, obviously, brain development. So if I have a child who was just born, not much white matter exists yet. And so not much of the structural buildup is finished yet. So I may not have that child show me what my migraine is. It may come in an atypical presentation because the channelopathy isn't quite there yet, but it may be there somewhere, but it may still be shed because after birth, the brain tends to sort of kind of trash a lot of excess growth. And so it may be trimmed after a while. And if it is trimmed, we will never find it. So we have to wait for the maturation, the actual maturation of the brain, which would be at like 30, 34 for males and a few years less for females, before we can actually then state this is the brain region that is representative.
And does that locus change over time, or can it be different for different migraines in the same person?
Oh, absolutely, it can. And so this is one of the reasons why I'm saying there's no different migraines. All migraines are migraine. There are no different types of migraine. Like they name a ton of different kind of migraines, but they're all the same. What differs is the location, and that can move. So I personally have experienced aura migraine, hemiplegic migraine, classic migraine, you name it. I'm experienced just about all of them. And I have many members in my migraine group. Suddenly, just the other day, one of them said, I've never had an aura in my life. Suddenly I come down with aura. So yes, it changes. It totally depends upon the brain region. That
basal ganglion thing is fascinating, because that again is the rudimentary, the oldest brain system, and that autonomic nervous system, parasympathetic nervous system, can affect all of those organs.
Migraine is very much connected to what I call the lizard brain. When you're looking at the more ancient part, which is because one of the what I call the tri-migraine system. So I have a complex that I call the tri-migraine complex, is how I set up migraine. It goes through all the emotive part of the brain, and it actually generates a fight or flight syndrome. So if you have a brain region that suddenly experiences the inability to fire electricity, that's a very big thing. The voltage is crucial, right? Mm-hmm. So there will be a panic attack. And there are several steps to this, but a panic attack within the brain is going to be initiated because the brain, as smart as it is to operate us, it doesn't know what's wrong with it. So it's not familiar with itself. And so it's going to initiate a series of steps to first troubleshoot, then also to solve the problem, to resolve the problem. And so one of the solutions that it finds appropriate, which sometimes actually works, is to initiate a fight or flight. Because what happens in a fight or flight is, first of all, our blood pressure increases, the blood oxygenation increases, the blood heart rate increases. So suddenly more electrolytes will be traveling all over the place and faster. So that can resolve the problem. But with the fight or flight, we now suddenly enter into the emotive part of the brain, the lizard brain, of what we do. Are we going to fight, or are we going to run away? And whatever we choose to do is going to create different kind of situations. But it connects very much to the primitive brain.
Right.
And so there's absolutely no wonder that it starts in the primitive brain, because it's very much part of it.
And that's why we have those somatic symptoms that are not pure sensory or motor, but they're more visceral. Along those lines, again, I'm bouncing a little bit because this is how my brain works, but there are two or three conditions I'm thinking about, and you can tell me whether these populations have a greater incidence of migraines or a lower or the same. The first one is, and we're seeing this now, 2019 statistics in this country are that 1 in 44 8-year-old kids have autism spectrum disorder, which is a white matter dysfunction. And obviously when you're going to feel symptoms, they have to be translated back and forth, or channeled back and forth down the systemic nerves. It's not just in the brain. And the question then is the rate, the incidence and the frequency or occurrence of migraines, or the perception of that, different in the autism spectrum population? And what is your knowledge and thoughts about migraines in that population? Because our belief is that autism is not a genetic condition, it is a substrate condition. And so therefore, the genetics of migraines should be identical by percentage, whether they have autism or not, because it's a pre-existing genetic condition with an environmental overlay, but a disruption in the anatomy of the white matter of the brain. Little complex to follow and understand, but what are your thoughts?
So I actually have two parts to that, and it's not complex for me at all, because part of my research originally, my dissertation was going to be in autistic children and the cause, which I have a completely different hypothesis. And another faculty for whom I wanted to end up working as a postdoc ended up solving the mystery. So I will tell you about it as well. But let me go back into the general population. In my migraine group, I don't have the general population. I only have the population that is Facebook savvy and some of the parents who are Facebook savvy. I do have a couple of parents who have autistic children, but I don't have enough information to tell you whether these children have more or less migraine or not. And also some of these children may not be able to communicate if they have migraine or not. So we may not know what they have. But in terms of the brain, it is entirely possible that if you have one particular kind of brain change or variant based on genetically, then it may preclude other kind of variant changes. And so I wouldn't know if autism was genetic, would that automatically preclude some other kind of genetic conditions in the brain? I wouldn't know that.
Let's assume that autism is not genetic.
But we assume that it is, but it may or may not be. So we don't know.
My assumption is that it's not. My personal assumption is that it's not.
Right.
But and that's my assumption. That we can argue. Yeah.
Right. And that's also my assumption. There are some exceptions where I can see children, but they deeply have other kind of conditions as well. So we don't know which one came first. Is the chicken or the egg? But in terms of autism in general, when I did my dissertation, and I had a lot of choices of what I wanted to do, and my topic was oxytocin. And the oxytocin is a hormone that is released by the mother at the time of giving birth. Also, of course, milk, leptin, and so forth. But it's primarily a bonding hormone. And the importance of all these points, that the birth, where bonding is important, the release of the milk, milk let down is led by oxytocin. And it is also the one that starts the actual labor. It creates the constructions of the uterus. And we didn't have so many autistic children prior to our Pitocin for the parents to start labor. And so my investigation was going to be to see if the Pitocin, which is basically oxytocin, just in a generic form, if it is released naturally in the mother, it's released only at just about the time when the baby is born. It's not released before. And is the brain ready for that amount of oxytocin to be released in time? When the mother-to-be is on Pitocin, it's an artificial induction of the oxytocin in order to initiate the labor itself. So may it override the brain, and may it create an autistic-like behavior, because oxytocin is the bonding, it's a social hormone. It's also called the love hormone. And so we have two kinds of autistic children, ones who are incapable of emotion and love, and ones who are overly emotive and overly loved, right? And this is a general broad category. And so there was a lady whose name is Sisu Carter, and I don't know if she's still alive. She was in one of these universities that I wanted to end up working with her. She was using bowls. These are little cute mice looking things, but they're two kinds, and they live only wild. They're not typical for lab use. And there are two kinds. One is a very socially bonded kind, and the other one that is not. And so they were perfect for her experiments to see how oxytocin worked with these two brains. And then she did an experiment in which she sacrificed the babies. So she would induce one mother with Pitocin, not induce another one, just giving nothing whatsoever, and a third inducing with saline just for a placebo, and took a look and allowed the mothers to give birth, allowed the infants to be born properly. And then she sacrificed the infants and looked at the brain slides. And she looked very specifically to find the oxytocin receptors in the brain of the infant voles. And she found that those voles who were given the Pitocin, the receptors for oxytocin was literally, they were burned off. They didn't function, didn't exist. Whereas in the natural or the saline, nothing has happened. And so some of the infants, some of the babies she kept, and they all were autistic in terms of what we would call vol autistic. So they didn't have bonding, didn't socialize, so forth. And so when I'm looking at, this is what I wanted to look at in humans. Obviously we can't sacrifice babies and test their brain cells, but I was going to look at just statistics. Did this mother get Pitocin, and did that child develop autistic tendencies? And so nobody, of course, would release the data for me. No hospital would be stupid enough to do that because it's a lawsuit in the making. And so we don't know. So it's a hypothesis, but based on the studies on voles, it's clearly shown that in fact, it is not genetic, but there might be a genetic predisposition to being sensitive to.
The genetics don't take it from 1 in 15,000 incidents in 1970 to 1 in 44 in 2019. No matter how effective we become at diagnostics, it doesn't explain that incident. So the genetic theory, I don't think is relevant. There might be a minor predisposition. That's an interesting concept. I'd like to, I love that. And I want to explore that a bit more, but I want to get back. I know we haven't even started.
Oh, we could go for hours, right?
But the other question I have, and I actually had a patient this morning that I referred to you, and she had a motor vehicle accident, had a TBI, a traumatic brain injury, and has started suffering, has been diagnosed with migraines by her physician, by a neurologist, after the traumatic brain injury. And I actually sent her to you because I'm not certain that is a correct diagnosis, but I don't know all the criteria. That's why we're talking. The question is, do you have any knowledge of TBI and association with migraines?
Absolutely. I have many members actually with TBI, and it's increasing, unfortunately, for whatever reason. Now, given that migraine is genetic, but as I noted earlier, it has to be expressed at one point, and it's based on epigenetic forces. So if somebody had the possibility of having a migraine brain based on inheritance or other factors, it could just spontaneously also arrive, but it's still going to be genetic. It can, in fact, be initiated by a traumatic brain injury. So there's no difference there, but I will diagnose. And of course, I'm not an MD again, so I don't diagnose, but I just sort of have a criteria that I set up for my understanding of whether this person is a migraine or not. And I apply those questionnaires. So I will ask the person, for example, where does the pain hurt? Because most people think of a migraine as a very big headache. But of course, migraine often happens without a headache. So clearly, migraine is not dependent on having to have a headache. And also migraine headache.
That's an important point. I just want to just say that again, because that's such an important point that I was unaware of, that migraines can happen without a headache.
Absolutely. Absolutely. And there's a pathophysiological explanation to that, which I can also give. It's complicated, but migraine, in fact, I would say about 15% of the migraines don't have associated pain, primarily because the migraine can resolve, because the brain is capable of resetting the particular condition.
Sorry to interrupt you there, but is that the population that have an aura that is not doesn't become a headache? Because I read about that a little bit in preparation for this. Is that different from that group?
Okay, so that group is known because for most cases, when you see the aura, it's starting at the very back of the brain. And so there is what's called a cortical spreading depression. I don't know if you're familiar with what that is. Okay, so think of somebody had a heart attack and you have they're putting on a CPR machine to sort of start the electricity. In the brain, a cortical spreading depression is exactly the same thing. It's a self-created CPR machine that is within the brain. And what the brain does, this is one of its solutions of the many that is over the years have evolved, is that, okay, so some part of the brain is not functioning, and the functioning is lacking as a result of electrolyte imbalance, which is actually the cause of migraine. And so that neuron is not communicating, it's down. And so the neighboring neurons send a signal, there is something not right here. And so a particular part of the brain, and where it starts is usually in one spot, but it's a spreading depression, which means it's a depolarization. It changes the ionic channels all the way through the brain. It moves with about 2.5 to 5 millimeter per minute. So it's a slow moving activation of the entire brain. And so as you well know, what we see with our eyes is transformed from dots and the colors and shadows, it's transferred into an actual electrical signal that we can comprehend as a table or a chair, what we're looking at. As this electricity is moving through the brain, it activates each neuron, which then gives us an electrical signal. And the occipital cortex thinks we're looking at something. It doesn't know that we're not looking at something. It receives these signals. And so what we actually see, sometimes very beautiful, sometimes just really weird, we actually see the cortical spreading depression moving through the brain. We're activating the neurons being activated one by one. Nobody's talking about this. Right. And this, again, is my explanation. And it's a completely logical explanation because our occipital cortex doesn't know what we are looking at. It just thinks we're looking at something. And so this is why an aura migrainer closing the eye can still see it, because it's not in the eye, it's in the brain. And if this cortical spreading depression was successful, meaning it completely reset the ionic structure of the brain, and of course our heartbeat, every heartbeat changes the ionic osmolality and it's changing the blood. If it was successful, there will be no pain. We just had an aura. Okay. But people who have aura, they'll notice it. Oh, I had an aura, but it's not gone. And other people with migraine, they may not notice anything. They may have a prodrome instead. It doesn't mean they don't have the same thing. They have the same thing. It just doesn't have a visualization part to it, perhaps because this cortical spreading depression starts in a different part of the brain. It may be heading in a different direction. And it's not hitting the occipital cortex exactly in the same direction as if it came from the eye. I don't know where it actually starts. And I couldn't even tell you if it starts all the time in the same place. I'm suspecting it doesn't, because if I can sometimes have aura migraine and sometimes not have aura migraine, that means that the direction is changing. And right. So there's no fixed point of start. So.
Okay. So let me unwind all of this, because I went sideways into the kids. I was really interested in that. But I'm going to ask you the same question from two different perspectives. And the question is simply, what is a migraine? And the response I'm looking for is, one is, what is the descriptive of what is a migraine and what is not? What's a cluster headache? What's other forms of headache? So how do we describe migraine as the first answer to that? And the second part to what is a migraine is, what is the biochemistry? What is the pathophysiology of a migraine at a chemical reactive, from a chemical reactive part? And I know that's where your knowledge base is, but if you can just from a layperson's perspective, okay, sure. I've just landed here from Mars. This is what encompasses the broad category of migraines, knowing that it is diverse, but where are the boundaries, and then the biochemistry?
Okay, so very good. So the boundaries, and this is very important because this is where all the confusion lies. The brain is two completely different hemispheres, and they function completely differently. And so if I have a migraine, and I explained earlier, I may lose my speech, which is on the left side. I may lose half my body, that would be on the different place. It tells me that a pain associated with a migraine can't possibly be on both sides of my head, right? I mean, if I'm just going, for whatever reason, my brain in one area is going down and I have symptoms on that one side, then I shouldn't have the headache in more than one side. That too is just one side. So by definition, this is my first question, where is your head hurting? Because if it is on the forehead, which is both sides, or the top, or behind both eyes, or if it's in the back of the head, or the whole head, or it's moving, that's not a migraine. Migraine will be one side, and it's going to be like somebody just hit you with a hammer and it's still in your head. And it's going to be there for days. So another question then is, okay, so if the hammer is in the head and it's just there, then that's not throbbing. It's not a throbbing headache either. It can't have any pulse. It's not associated with blood pressure or the flow. It's not a vascular kind of a problem. And so already two things we've excluded, which are very common. We suggested that migraine can be anywhere, just a big headache, or that is a throbbing headache. It's neither. In fact, a real migraineur bending forward, head down, meaning positional changes, will not affect the intensity of the headache. Because
and that's opposite to what a lot of the literature says.
Exactly. It's very much the opposite. And that's probably because by the time I used to go to the emergency with lots of migraines, I mean, there wouldn't be a week without an emergency visit. It was ridiculous. But by the time you get to the point of having such a bad pain that you can't control it, at that point, your whole body hurts. You have no idea what is hurting. And at that point, it appears like you're hurting everywhere, but you aren't hurting everywhere. You're just, the initial point is where you're hurting. But it's just like if you break your arm here, it doesn't mean it can't hurt here also, right? You can be hurting, and it just doesn't mean that we know that the break is here. It's not here, or it's not here, but yet you're hurting in your whole arm. But the initial pain was here. So when you have an initial pain that starts on the top of your head, that's not going to be a migraine. Or if an initial headache that starts on the forehead, there could be, for example, most migraineurs will have a moving pain. So for example, if I'm coming down with a bug, it's going to affect my electrolytes, and I'm going to get a warning pain, which is going to be on my opposite side, one spot, one place. And then as my body is fighting the bug, depending upon how successful it was fighting it, whether it will become a migraine or not, meaning if I have disrupted my electrolyte tremendously, it may move to the other side. So I may go to bed with the pain here and wake with the pain here. And then I come down with a migraine. So it can change, but it doesn't ever hurt on both sides at the same time.
But it's not a throbbing pain, because that's what, typically it's been described as let me just see what my notes over here say, is that it is that throbbing pain, yes, one side, but a lot of what you've said disputes some of the conventional descriptions of this.
So let me get back to the throbbing, because remember how I said earlier that it connects to the primitive brain. And so the primitive brain will activate the fight or flight, and the fight or flight will change the blood flow. So once a person is deeply into migraine for several hours, it may feel like throbbing, because by then the blood flow and everything is changed and activated. I mean, the body is in a panic mode. And so at that time, it may feel throbbing, but the initiating pain is not a throbbing pain. So if I sit here, I'm talking to you, and if I come down with a migraine, first of all, I will have prodromes which precede it. So I will know I'm going to come down with something. I just don't know what those are. But the pain is going to sort of kind of start in one spot, and it's just going to stay there, and it won't move. It may intensify very slowly. It's not going to go like kaboom, like a thunderclap headache, which is a sudden onset of a headache. It's not going to be like that. It sort of kind of builds up to a maximum within about a day, if it's going to last for more than a day.
Let me stop you for a second, because you've used a word consistently that I want to question. It's the word pain. My understanding is that the brain itself does not have pain receptors, but the meninges, the membranes around the brain, have pain receptors. So when you're using the word pain, it is, again, this is beyond my understanding of the brain. I'm not a neuroscientist by any means, but my rudimentary understanding is the brain does not have pain sensation. Right. So when you're perceiving pain, what are the receptors? What do you mean by pain?
Okay, so there are no receptors in the brain. So brain surgery is done without anesthetics for that reason. The sensory organs are on the meninges, on the dura. Between the brain and the skull is a thin tissue that separates, so that the brain is actually not touching anything under normal circumstances. And so these are called nociceptors. And so these nociceptors are the ones that are targeted by some of the latest medications like CGRP inhibitors and so forth. They're the pain sensory organs. So if I have a pain here, it doesn't tell me where in my brain I have a problem. It just tells me that the signal that I received is at that spot. And it seems that for most migraineurs, the spot seems to be the same all the time. So it's almost as if one particular pain sensor was assigned for this kind of a pain. This is just a hypothesis, I wouldn't know. But it almost seems that way, because I never ever get a migraine kind of pain anywhere else on my head. It's always on the exact same spot, without exception.
So it seems like the actual brain site correlates more with, Because the brain, as you've described so often, is that there are regions that govern certain things, speech, vision, abdominal discomfort. So that the part of the brain that's been regionally mapped is more accurate for the locus of the brain than where you actually sense the pain on the surface.
Exactly.
It may just be a low point where pain is more readily, the nociceptor pain in the membranes.
But let me take it.
Yeah.
Okay, just a step further is that you may have the pain anywhere on one side, but it's the symptoms that's going to tell you where in the brain actually the problem occurs.
Right. So the fact that you've got pain suggests that this could be a migraine, but really what defines the migraine is actually a brain issue. And we'll talk about the biochemistry of that in a second, but that is typically related to the position on the brain where that governs a certain response. If that
makes some function
that's why it's the association with oral functionality is such an important part, and that's why it can be motor, it can be sensory, there are a variety of, and autonomic, I guess, is because I wrote ANS, I wrote autonomic nervous system down as a question for you. So that's interesting. So it depends on where that locus is. In terms of the palpation of pain, is that related to vascular swelling or what type of irritation is the meningeal irritation happening? Because that must be different than the source of the ionic changes in the brain itself.
It's connected to it. And that's because the ionic channels themselves, their job obviously is to modulate, in this case, the sodium, potassium, ATPase channel, and sodium channel, and the potassium channels, and the calcium channels. These are the ones that we're talking about that are modified in terms of genetics in the brain for a migrainer. And so we don't know whether this means that they use sodium or potassium differently, whether they allow them in less or more, but we know they're modified. So they're not going to react the same way as a person who doesn't have one, this particular problem. And what that actually means that if I change the osmolarity of my electrolyte.
Let me stop you for a second.
Yeah.
Is this specific in the gray matter neurons? Is that the cell we're talking about?
It's right. It's actually the area that we are talking about is very specifically in the nodes of Remier. So when you're looking at a neuron, so let me explain for the viewers that they don't know. So when we're looking at a cell, like on our skin, we typically see a sort of kind of roundish, flattish objects. That's not what a neuron looks like. So a neuron would look like small or long. We have very long neurons that go from our lower back to the legs, but we also have small ones. But they have this, they have a head with dendrites, little arms, like hairs, like think of Einstein with the hair standing up. And then there's a long body part, which is called the axon. And that part is the main part of the neuron that we are now going to talk about. And then, of course, on the bottom, there are the boutons, the feet, which then release the neurotransmitters, the neuropeptide packets. In the area, the axon is the one that carries the voltage. And the gray matter itself is the brain cell. And the white matter that is surrounded is the myelination. And that's made from fat and cholesterol. But it looks like a bunch of little sausages. So think of it, if I have a neuron that is, say, that it's this long, the axon is this long, and say I have 5 areas where it's myelinated. The myelin is basically insulation. So think of like a cord, an electrical cord that is insulated, but in 5 places, there may be the insulation is cut. So in 5 places, the copper wire is visible to me. If I'm looking at the neuron, that's what it looks like. And the areas where there's no insulation, that is the area where all the pores are around the neuron, where the sodium, potassium, calcium, magnesium, glucose, whatever goes into the cells, those are the places where it can go in because it can't cross the myelin, which is quite thick. It's much thicker than the neuron itself in diameter, several times thicker. And so the myelin's job is to help maintain the electricity as the voltage is going through the cell, because this is an organic voltage that is being generated. And so we think of voltage like plugging in something in the wall and kaboom, we have light or TV or whatever. But in the brain, the exact same thing is being recreated from point to point to point to point. So at every single place where there's no insulation, the sodium will enter the cell and action potential will start, but it has to move to the next area. And so it's in a rhythm. It's referred to as a spike train, because it's like spike, 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 but of course in milliseconds. So we're talking about very quick activity here. But the electricity is generated here. The voltage.
Just to understand, electricity is electrons, but this is a chemical.
It's a chemical, but it's an electron, right? It's the same idea. It's just done with electrical difference.
We're using electrical terminology to make it more comfortable to understand. I've had pushback.
To understand it, because that's how it's always represented as electricity. But it's basically it's a charge moving through, and that creates a current, which is voltage. And so, but it's the electricity that carries the voltage all the way through. And so we always see this light moving through very quickly if you're looking at diagrams, but it's not like it's moving through this quickly at every single nanometer.
Jumping from node to node to node.
It's jumping from, it doesn't actually exit the cell. I mean, it has to be within, it's on the inside. And so this is referred to as a spike train, that this jumping movement, but we forget that this is electricity doesn't just jump. It has to be continued and picked up at the next spot and recreated. So even if you're looking at the electrical cord, it's like one electron hits another one and that hits another one, right? So it goes that way. And so the electrical point, the points at which the voltage is created, even in an inorganic system, is from point to point. It's just very tiny. We're talking about the atomic, subatomic level. The same thing in the brain at ionic level, which is either a molecule or an atom with an electrical charge. So we're talking about the sodium entering the cell here, creating voltage potential, and then the next sodium channel also gets the sodium in, continues that voltage potential, and so on, all the way through the cells. Now, imagine the same neuron. What if in one area we don't have enough sodium? The whole thing just stopped. And so what we do know is that action potential is an all or nothing. So what that means is that it either happens or it doesn't happen. It can happen in such a way that it started, but then it fails. So it never actually occurs. It never happens because it dies off before it happens.
And if I remember correctly, there's always a threshold.
There's a threshold, and I think minus 70 millivolts is the standard, and then it jumps to plus 30 or 40, and then it falls down to like minus 100 is the minimum. I don't know.
Get the nerd out of me. 1981. So, but I remember some of that from way back.
I'm looking at the drawing in my brain as I'm talking to you.
Potentials, and we studied
that. Put two scientists together and the world comes to an end. But so yes, so if you're looking at it this way, if you're looking at it as chemistry, but it's also a lot of physics. Obviously, it's pure electricity, regardless who is making it and how it is made. It's pure voltage. And if you're looking at it this way, if I suddenly lose any part that is responsible for generating this particular voltage, then it stops. It's unable to continue. If it's unable to continue, that neuron just stopped working. It doesn't have enough power to generate a voltage. It can't send messages because basically the focus and the reason why it is generated is to send the neurotransmitter as a packet of message to the next neurotransmitters that are connected to it and who can pick it up if they want to. They don't have to, but they can. But if this neurotransmitter just suddenly stops working, then it doesn't send signals. The other neurons around it they're expecting some kind of a message, and suddenly there's no message. So they also can't transfer that message. And so there's going to be a void, and that is a void in function of the brain. And so we know that if a cell, a neuron, stops communicating, that neuron is going to be trimmed. That's going to be a degenerative activity within the brain. So the brain will look at this as something is not right. I am sick at that part because that part has some sort of a boo-boo, some damage to it, and we got to fix it. And so the entire process through the white matter and the gray matter, it occurs in the gray matter, but between the white matter. So you can't really specifically separate it. But if it happens a lot, and it happens so very often, then it damages the white matter as well, because the white matter needs to be replenished continuously, and that requires a whole lot of nutrients and functions to happen. And the glial cells create the myelin around the neuron. That also isn't going to happen.
So a second, just for the myelin sheath, which is in the oligodendrocytes in the brain, is made of fat.
It's made of fat and some cholesterol, right?
Fat and cholesterol. So those can be made internally in the brain, but they have to be provided by substrates.
They have to be provided by substrate, but also the thing that then converts them into myelin has to also be working. And there has to be a message from the neuron that I need myelination here. It's not just happening randomly wherever the brain wants to create myelin. Right. It has to be very specific around certain kind of parts of the neuron. And so if the neuron is not working, then it's not instructing that from happening as well. And so we're
talking about two separate things that I'm just wrapping my head around this. We're talking about ion channels in that little gap in the myelin sheath, but then we're also talking about the insulation effect of the lipid moieties themselves. Where in migraines, is this an ionic problem or is it a lipid problem?
It's an ionic problem, but it ends up becoming a lipid problem. Because when you look at the MRIs, for example, of migraineurs, or sometimes even on CT scan, it may be able to see. But on the MRI, it's very clearly visible that many of them have white areas on the myelin, some damage. And it's very typical for migraineurs to have these lesions on the white matter. So
let's bring this together. Because you've mentioned two seemingly separate things, but in my head and in my background, I would suspect that we're going to have a communal answer, because I don't like answers that are disparate. I like everything to be tied together. So, so migraines are an ion influx problem, and you're saying the ion that we're dealing with is sodium. It's a proton. And so what is the problem with sodium? Is it a lack of salt in the brain? Is it the salt is not flowing through the channel? And there's always there's always two parts to this. It's a sodium potassium channel or a glucose sodium channel. What is the opposite side of this, and what is the exchange typically? Do we know?
Okay, so we have a ton of things that you just unleashed. So one of them is that the migraine brain is anatomically different to start with, and not just by the ionic channels, but by the sensory neurons. Because if you compare a non-migraineur and a migraineur in terms of their sensory neurons, you're going to find that in a migraine brain, lots of literature on this, by the way, in the migraine brain, the sensory neurons associated with the nose, the eyes, ears, mouth, touch have a lot more connections to each other than in a brain of a non-migraineur. So that particular migraineur looking at a light is going to see a different light from a non-migraineur. It's going to see it more intense. So it's using a lot more neuronal energy when just by simply being, it has a lot more sensory organs working. So we can smell things that we're like the dogs of the human world. I mean, I smell type 2 diabetes, cancer, you name it. I smell it. Gas leaks famous. How many migraineurs have sent the gas department out to measure because nobody smelled, but they did. We hear amazing sounds. We just have amazing peripheral vision. I have glasses and I don't see well, but boy, you can't pass me in my periphery a fly without me discovering.
There's the hypersensitivity.
It's a hypersensitive brain. It's a different brain. And so it needs much more sodium. So by you looking at the same light as I do, I use a lot more sodium than you do. And so there's a study from 1951 that points to migraineurs excreting in their urine 50% more sodium. And so this hints at a much higher volume of sodium use. And in fact, I had one of my migraineurs in the migraine group having a urine test, and I asked her to also test sodium, protein, and other things because we had some issues to look at. Her sodium was 50% higher in the blood, in the urine than the expected maximum range. And so we have a different brain. We use a different amount of sodium. So what is defined as eating, for example, a meal with the proper amount of sodium or salt, in this case, is not sufficient for a migraine brain. It isn't.
And sodium has to be supplied from the diet. It's not something that's stored internally. Because we know sodium is very important in terms of blood volume and blood pressure intravascularly. And the renin-angiotensin system manages the hygroscopic nature of blood vessels. Is that what you talked about, or is this sodium outside of the blood vascular system?
Okay, it's both, because we're talking about migraineurs also being salt wasters. So they tend to excrete the sodium rather than recycle it. So their entire kidney system functions differently as a result of the need for the excess sodium. because our brain may need extra sodium, but the rest of our body does not. And so, in fact, most migrants have very low blood pressures. I don't know if you know that. And so clearly, yeah, because the literature again says that they have high blood pressure, but they don't. When they have pain, they do. But if they don't, then they actually have low blood pressures. And 90/60 is very common in our group. And mine is about 100/60 usually. And so it can change based on how your kidneys and the rest of the body operates with what you have to do in the brain. And so when we're talking about sodium intake, if you take the sodium with food, it is going to be absorbed more through the intestines than through the electrolytes. And actually the goal for us to be absorbed into the electrolytes. So my migraineurs and I myself take salt with our water because we want to directly increase the blood volume and to, now you asked a question some time ago, which I didn't respond to for whatever reason, we sort of derailed. And that was what specifically did the pathophysiology of the migraine within the brain at the ionic channels. So if we don't have enough sodium, then by definition, we releasing a lot of water from the cells. That's just by osmolarity pressure that will change. And so there is going to be a little bit of a swelling at a certain area of the brain because it's water can come in and go out without any control of the sodium holding it. And so most migraineurs will, for example, end up with edema. That's a very—
Let's stop you for a second there. I just want to explain that sodium regulates blood volume or sodium regulates volume. In other words, thirst is not a hydration, a water problem, it's a salt problem.
It's a salt problem, exactly.
And I think that a lot of people don't make that connection, is that sodium regulates water, not water regulating sodium.
Exactly. And that's a very big problem too, because when you're told to drink a lot of sodium or drink a lot of water, you're actually diluting and you're causing a bigger problem. So I oftentimes tell people, well, have a little bit of salt and maybe not even water at all. If I feel thirsty, I will not drink water. I will have salt first to see if that's all my problem, because, and here we tie to the nutrition as well, and also the metabolic health, because another very often forgotten principle is that when glucose enters the cells, it has to displace both water and sodium. It has no other way.
That was a question I was getting to when I asked about potassium and sodium channels and glucose channels, is they are competitive with each other. They're all protons. Well, glucose is not, but the others are protons. How does hyperglycemia affect sodium levels at that brain level?
Right. So, well, we know that we have two kinds of glucose transport systems. So we have the insulin, which uses only GLUT4 receptor uses insulin.
And the brain doesn't really have a lot of GLUT4 receptors.
No, only certain parts do. And the brain actually doesn't even use insulin. And I believe the insulin it can cross the blood-brain barrier, but it's
very, very slow. Yeah.
Right. It's very, very seldom. So the brain actually uses, I believe, GLUT1 to cross the blood-brain barrier and GLUT3 inside the brain. And these are sodium transporters. So what that actually means is that these are active transports, but they're active in a special way. So I would call this a secondary active transport, because the sodium comes out of the cell. By definition, sodium will be coming out of the cell, and it opens the gate to have sodium come out. And with that energy, glucose can go in. But glucose is 6 molecules of water as well. And so there has to be a replacement of water. So when the glucose enters, water and sodium will exit. And so if water and sodium exits and they go into an interstitial space, which is outside of the cell, and oftentimes water then, in this case, is free water. It's not connected to the electrolyte because it's squeezed out without it. Then it's going to go outside of the interstitial space to Neverland, collecting as edema. And so that's going to be a problem. And
well, it dilutes the sodium as well.
It dilutes the sodium. So we now have less sodium than what we need. And it will cause an imbalance between the osmosis between inside and outside of the cell. And of course, being that potassium and sodium are the same charge, they're positive, both of them are positive, they will repel each other. And so they head in different directions. And the inside of the cell should have a lot more potassium inside than the outside. And the sodium should be only on the outside rather than on the inside. But the electricity is driven by the exchange of these two. And there's going to be an imbalance left at the end. So the extra sodium can exit the cell. But
so let me just clarify something here for a second. The sodium glucose channel, the GLUT1, GLUT3s, are related to energy provision or substrate provision to the cell, where that's an important channel to get sugar into these cells,
Right.
and both into the neuron, which can use both ketones and sugar as a fuel source. But the oligodendrocytes in the Schwann cells can only use sugar. They're glucose obligates. So
Or lactate.
Or lactate, right.
Lactate.
They don't use ketones. They don't use fat
Right.
as energy substrate. So they need this continuous inflow of energy because they're using energy all the time. And
Exactly.
that's one sodium glucose pathway. Then the other one is a sodium potassium exchange, which has a different purpose.
Exactly.
Both triggered by sodium, but the water dynamics make a big difference as well. And then glucose gets phosphorylated inside the cell and can't leave. So,
exactly.
Okay.
Right. And also the protein. I mean, the cell inside is really dense. It's full.
Yeah.
So whenever something goes in, it has to take something out. It can't just go in. It's not like there's free space in the cell. So by definition, anything that enters the cell will cause some kind of a chaos. Somehow something has to come out. And it could be under an orderly, organized fashion, or it could be under a completely disorganized fashion. And
just
so
one other comment, let me just stop there for a second, because yes, what goes in has to be balanced, what goes out. However, if I remember correctly, the sodium glucose channel is energy driven. In other words, it can work up gradient, whereas passive diffusion is always down gradient. So you can have that slight mismatch in terms of volume.
Especially because of the gradient, that it has to be, it's an active transport. And so we have primary and secondary transport systems, and the sodium transport is a secondary, meaning that the system, some of the sodium transports are actually primary. So when we're looking at the sodium potassium ATPase channel, which is primarily to reestablish the membrane potential for the cell so that it's not about to set up an electricity in that spot. So it's in refractory mode. That is going to be a primary channel. But all the others may be secondary in that they will use the stored ATP that is created by this particular motion of the primary one. It's going to create a motion, and that electricity, that energy, that is that ATP that's released, not electricity, but ATP that released, can be used by this other transport system to get in or get out of the cell.
Wow, it's so simple to understand, but it's so complex.
It's very complex.
Yeah, but the beauty about the human body is it works the same everywhere. It's not like this is a specific thing to the brain. All cells function in the same way. It just has unique properties at different cellular levels. But the human body is fascinating in that it uses the same process everywhere. And you just got to understand how those things function and work. So, okay, so we've got a lot of information about the sodium potassium channels. So what happens in migraines?
Okay, so in migraines, when there's not enough sodium in this one particular place, or sometimes it's not enough potassium, by the way, because they both help the action potential and the resting potential would be by the potassium. So if one of these two is not in the right amount.
Let me just stop you for 1 second. Again, I'm thinking back 20, 30 years to my science, is that the percentage I have, and I may be slightly off, is that about 96% of potassium is intracellular and about 4% is extracellular, and it's the opposite for sodium.
Exactly.
So there's always going to be an abundance of potassium that's locally available because it's inside the cell. The sodium is less likely to be always present because it is connected to the bloodstream where it can move away as well.
Totally correct. And we have to also consider that sodium and potassium have different sizes. And so they're different amount in terms of numbers in the human body. But as far as weight is concerned, they weigh about the same because they have to come and go approximately equal. So when you're referring to sodium being out and potassium being in, for example, the sodium potassium ATPase channel that I referred to, which is a very active channel, it will have room for 3 sodium atoms or ions, and they will have room for 2 potassium ions, and they work such that as the sodium exits, the potassium enters. But the potassium has to enter. So if there's not enough potassium in the extracellular place coming in from your diet or recycled by your kidneys or from any other place, then you may also run short of potassium. And this would be quite critical when, for example, there may be some edema. Say you have not enough sodium and you have a lot of water coming out of the cell causing edema, and you have a lot more potassium in the cell, but it can't come out because simply there isn't enough sodium to replace, because all of these are electrically charged. So you can't have just potassium come out. There can be potassium.
There's got to be an exchange, yeah.
It has to be an exchange. And so if you don't have enough sodium, that also retards the amount of potassium. And so whichever you end up having a little bit more deficiency is going to be the problem. So in terms of migraine on a day-to-day work, so to speak, of how to prevent or stop a migraine, is that one has to evaluate, what exactly do I need now? Do I need more sodium or do I need more potassium? Because it's not necessarily both. It's usually not both. You either need more sodium or more potassium. And you need to understand from the signs, the symptoms that you're getting, which one your body will right now need more. And so the trick is that with potassium, it takes a long time for the potassium that you eat to get into the system, because we don't take it by supplement, because that just gets into the blood where it's the wrong place. It can't get out of the blood. Whereas sodium, we can take as a supplement, it gets into the blood, which is where it should be. And so we need to prepare appropriately. So for example, I will ask everybody to eat a very high potassium diet, balanced at best 1-to-1 with sodium in the food itself. But when they drink water, drink it always just with salt, never with potassium. And that way, unless of course they have potassium need extra, then drink coconut water, which is a great potassium source without it being fake potassium. And then it absorbs differently and it resets the balance really quickly. And we have a way to evaluate which one we actually need. Because, for example, I can put a little bit of salt under my tongue and just close my mouth and just allow the salt to sort of melt and absorb. It will absorb right away. It's an ion, so it will go straight into the place. And if my migraine is reduced, bingo, I need to take more salt. If it gets worse, bingo, I need potassium. It's really—
Well, the interesting conundrum also is that salt, my understanding again, is that sodium has to be provided by external sources. We have to consume the sodium. Right. But pH, because most of your potassium is intracellular, small fluctuations in pH will also cause a change to your extracellular potassium concentration. And certainly the pH shifts that we see in diabetics and that kind of thing profoundly affect potassium more so than sodium. Potassium is more pH sensitive, and there's an ion exchange in that regard in the vascular space. And again, I'm looking to rudimentary basic principles with regards to ion exchange, but that is why the sodium is probably a first step to correct rather than potassium, if that makes sense.
I totally agree. And I would say that about 85-90% of the time, it's going to be a sodium, except for females. Some females during the menstrual cycle will go through a period where they may need more potassium. So they will go through what's called a chloride surge. This was a couple of articles that came out with the chloride surge, and don't claim to fully understand the system, but they have some of these migraineurs who I don't have a period anymore, so I couldn't experiment, but they experimented that if they massively increased potassium a couple of days prior to the start of the period, those who had this particular symptom, which meant, for example, massive weight gain overnight, like they would be, yesterday morning, they would be 130 pounds, and today they would be 133 pounds.
But that's edema. The only explanation for that is
it's edema. So it's a retained edema. So that means that for whatever reason, an imbalance occurred such that the edema has to be somehow collected back in and disposed of. And so depending
on— It's the same that's occurring here in a much more microscopic way.
Well, that would be a localized edema versus a systemic edema. Right. And so we distinguish between the two. So if it's a localized, such as in the brain, or sometimes, for example, we would get very swollen fingers or totally parallel, symmetrically swollen ankles. So it's not a heart issue, but we know it's an edema issue. That is going to be just sodium, to add salt and no water whatsoever. And it's just going to suck the water back into the blood, and we can then eliminate through the urine. But with potassium, it's different. So potassium is a systemic. It's all over the body and it's not visible. You don't see the swelling anywhere, but you gain 3 pounds overnight for no reason. That would be the retaining of the water systemically, and that requires potassium. Mm-hmm. I don't have a full explanation of the pathophysiology for this, because I would have thought that this too requires sodium, but apparently it doesn't.
Well, the other thing also that again, this is not my expertise at all, but there's got to be, at that time of the month for females, there's a steroid hormone change. Right. And part of this is adrenal cortex and adrenal medulla aldosterone, that type of change, which governs potassium levels as well. So it may be a steroid hormone cause rather than, in other words, driven by a change in hormonal milieu.
Right. It definitely is. Right. Yeah. It definitely is. I just don't have the full explanation for it. I just know that this chloride surge happens, and that then causes a more need for potassium. So these particular people, these women will stop all sodium. They will salt their food 1-to-1, but they won't put salt into their water. Sometimes they even cut back on the water, and they increase the potassium just for the period. And then once they regain their weight back to normal, they return to normal. And so there are two phenomena happening.
And I just want to stop you for a second, because a lot of people are listening, and they'll be saying, well, okay, I've got to add a lot of salt, but doesn't that cause other problems for my body? And I think one of the key principles that I like to explain to people in normoglycemia, assuming your blood sugar is relatively normal, the human body has an extraordinary capacity to handle an excess of salt. And the three areas that we lose salt is colon, kidneys, and sweat. We really struggle with hyponatremia. We don't handle low salt very well. We have to do ion exchanges with magnesium, potassium, calcium. The human body has a very poor mechanism of handling high blood sugar, but it has an extraordinarily good way of tolerating lower blood sugar by manufacture of sugar. So I always juxtapose those two. It's not directly related to migraines, at least not, I've got a little explanation to that as well, but I don't think that anyone should ever fear eating too much salt because the body can get rid of it very well. It's the lack of salt, and certainly in the migraineurs, that is a concern, is the lack of salt. But I think supplying it on a steady basis is better than just, jacking it up every now and then.
And I would like to just amend what you just said about the excess salt, is that a lot of people say, well, only if you have healthy kidneys. But then what I find is that the kidneys start improving. It's really fascinating, because some time ago, I needed a medication which just nearly took my kidneys down to the drain. I was down to 45 in my eGFR. And so they said, okay, so you will be on kidney dialysis within a couple of whatever. And here I am today with eGFR close to 80. Wow. And every time I go to the doctor, I say, how did you do that? Because it's just unknown to improve the kidneys. But it improves from the salt. Right. Because it doesn't need to do all that extra heavy work of recycling the salt all the time. It can just finally get rid of all that salt and clear itself. And so it actually benefits the kidneys. So I just wanted to say, for everyone who's scared of eating salt, it actually improves the kidneys, it improves the blood pressure, it improves everything, but all taken in context.
Now let me just add something else, is, tell me if I'm wrong, but it sounds like some of the sodium loss diuretics, the hydrochlorothiazide and Lasix and those kind of things, are terrible for migraineurs.
Oh, they would be, and they can't even take it. I mean, they have actually some forms in the group that they have to read and sign if they take some of those medications, because some of them may even actually interfere, because if they block renal reabsorption or excretion of sodium, or reabsorption oftentimes is also blocked, that can cause quite a bit of a stone.
Not only to sodium, but to potassium levels as well. So I think that must be one of the most disruptive medications, and yet they are a first-line treatment for hypertension, which is, I always try to get my patients off diuretics when we're talking about a ketogenic way of eating.
Right.